Welcome everyone to the panel on how can social and gender norms embrace contraceptive use? A very critical question, and we will hear results from 3 studies. Unfortunately, the study that was presenting results from Pakistan by Memon and colleagues, they are unable to participate. But we have 3 studies to hear with questions to follow. Again, open floor. Please take notes, think creatively, because this is a very important area, and we're welcoming some good discussion after to close out the conference. Okay, and again, the first presentation will be in French, so there was a QR code for interpretation. Let me introduce, please, Halima Moumouni Saleh, who is the chef de division programmation, suivi, évaluation et
research in the Department of Planning, Family Planning in Niger.
Of the Arme project, presented the research as head of the Adolescent and Youth Health Division of the Ministry of Health. And I will welcome Halima here to present the study Engager les hommes pour le changement des normes sociales.
For the behavioral change in the area of family planning by adolescents who are married in the rural areas of Niger.
To speak French very well, but please, Halima, you are welcome.
Good morning. So just as she introduced me, my name is Dr. Halima, Head of Department Programming, Monitoring and Evaluation and Research in the Ministry of Health in Niger. So today we are going to present our outcomes from the appropriate environment in Niger, SR Niger. So we will speak to you about committing men in changing social norms in the use of family planning in the country Niger. So the first thing is that we prepared this outline. After the context, we shall look at the interventions of the program, followed by methodology, outcomes, lessons learned, and the implications for the program. Now, as a background, the Nigerian population is 51.7% who are 15. And 76% of young girls in Nigeria are married before at the age of 18. 68% of the young women are already rather mothers by 19, according to the study in 2012. The contraceptive rate of the girls is 5.9, and we are at 6.2% in terms of reproductive capacity or fertility. Now, we have barriers here. So the obstacles in access to family planning, the obstacles of ensuring family planning, they are those that are mentioned by women mostly. And there's fear within the clinical areas where they fear nurses touching them. For religious standards, some women are saying that I cannot use family planning because of my religion. Decision taking. According to the study, we have 95.5% who say that it's my husband who takes the decision. Concerning the reasons why the women say that men who take the decision, some women say that they don't want children anymore. That is 68%. Now, interventions of the program. Now, in the implementation of this plan, PNB 2013-2021, the Minister of Health, in collaboration with the Pathfinder, established in 2016 a project reaching married adolescents, RMA, in the region of Dosso. Now, this project used a series of interventions to respond to crucial questions the way of changing attitudes and behaviors, as well as gender standards, and encourage the use of contraception among the adolescents who are married in Niger. Now, that said, this project is aimed at married adolescents from 13 to 19 years, and it is aimed at increasing the use of contraceptive methods, the modern ones, amongst adolescents who are married from 13 to 18 in 36 villages and 3 districts of Dosso, namely Loga, Dosso, and Induti. Now, the other objective was to try to create a proof on the effectiveness and cost of the interventions. The main objective is to identify the most effective strategy amongst the 3 approaches which were implemented, that is home visits, small group discussions, as well as the combination of the 2. Now, to achieve this objective, the project had an integrated package for community intervention aimed at modifying the environment, the immediate environment of the adolescents who are married by targeting the key influencers. They opted also for a significant engagement of the married people in the intervention aimed at changing their attitudes and mentalities and their behavior, but also the social norms around gender in their community to strengthen the support of their spouses in the search for the use of the planning, rather family planning services. Now, concerning the methodology, our approach was a socio-ecological model which wanted to aim at transformation on the individual level as well as social and structural levels. From the individual point of view, 3 approaches were used. That's home visits, small group discussion, and the use of the 2, as we saw in the Dosso commune in Loga, and a group discussion in Duchi district. At the social level, community dialogues aiming community leaders, especially the traditional chiefs, were held. Communities, mothers, and other influencers in the districts. At the structural level, we wanted to strengthen this health system through mainly 2 interventions, ensuring that there are services that are adapted to the young people in 36 districts, and developing the segmentation counseling approach to develop specific messages that are aimed and customized to the groups. In the methodology, we identified not only the target CSI districts, target villages, but also adolescents in specific areas as defined. We started giving information on the project and creating training tools and training of trainers and community leaders, as well as giving them equipment, and later they were able to carry out the job in small groups. Now, concerning FACOM, that is community facilitators, they went through the same process too, and creating tools, training, as well as having equipment so that they can undertake community dialogue targeting communities. What were the outcomes? Now, concerning the variables used, rather studied approach, we note that knowledge of modern contraceptive methods was significant. There was a significant increase on the combination of the 2 approaches. The ones that were undertaken in Dosso with an increase of 2.2% with a significant increase. Then, concerning the Loga region and what was done, there was an increase of about 2 points. Concerning the attitude of the adolescents in line with the use of contraceptives, we note that it was more significant. The use of contraception by the adolescents was considerable with regard to the combination of the 2 approaches which we implemented in the district of Dosso, followed by VID, which was implemented in the Boga district. Now, the mentality of people changed. with the VAD approach. Concerning the social norms, the social perception was also seen in the small group discussions. Continuing with the outcomes, the three approaches were really important in the use of modern contraceptives. Now, the most important changes in terms of knowledge, attitude, as well as social norms, limiting the utilization seem to be following the VAD approach. Concerning the lessons learned, the seasonal migration of the people, especially men, there where the study was undertaken is where it's the rainy season, the men go away to look for food, and that creates a challenge with the continuity of the service and study. So we had to take this into account to determine the ideal time to ensure that we can portray the key messages. The involvement of the health areas and the intervention zones as facilitators and ambassadors for the project enabled us to improve care for the women who were referred by Raleigh through Raleigh system. Now, concerning the community agents, the mentors and the community facilitators, this was significant in the use of tools and ensuring that they could work hand in hand with their husbands. And this also enabled the team to understand the context better in its implementation and ensure that the interventions can be directed where they are needed. The introduction of the counseling by segment approach improved communication between married adolescents and the service providers. Now, concerning the implications for the program, to ensure that there is effective change for social norms, which was the aim of our study, the actions must be undertaken in a combined manner, because we saw in the results that in DOSO, the combined approach, VAD and small group discussion, really had a significant impact. So this combined approach around the socio-ecological system is quite important. Now, at this level, we understand that when the structured program of VAD and small groups established with specific and customized messages, as we have seen in the methodology, adapted to adolescents, especially targeting men, where the subject of the study, contributed to ensure that there's an increase in the desire to change mentalities and behavior concerning family planning, and the strengthening of the health system leading to availability of services which are customized to young people, and continuing the supply, because if you create demand, you must create supply as well. To ensure that there's no stigma and other challenges. So that's the end of my presentation, and I thank you for your kind attention. I'm available for any questions and comments. Thank you. Many thanks. The next presentation is to be made by Dr.
Health researcher at the Demographic and Health Surveys Program, where she conducts research focused on family planning, maternal and child health, and quality of care. She also co-leads the Fellows Program, building capacity of university professors in different countries to use DHS data in their teaching and research. Dr. Rees also worked as a program implementer for USAID and CDC-funded programs for over 10 years. She has a master's degree in public health and international affairs from Columbia University and received her PhD from the Johns Hopkins Bloomberg School of Public Health in 2019, where she currently has an associate faculty posting in the Department of Population, Family, and Reproductive Health. That's quite the background before we get to the key findings here. And Sarah will present collective gender and contraceptive norms and modern contraceptive use among men and women. Please, Sarah.
Thank you very much. All right, well, good afternoon, everybody. I'm very happy to be presenting this work done in collaboration with two of my colleagues at the DHS program, Dr. Shireen Asaf and Dr. Jeff Edmeades, who is here with us. And so this study looked at collective gender and fertility norms and their associations with modern contraceptive use in Nepal, Nigeria, and Zambia. And the study was conducted with funding and support from USAID. So I wanted to start off with describing what I mean when I'm talking about social norms. So, social norms refer broadly to the behavioral rules and social expectations shared by a society or a community or a group. And when we talk about social norms, we're often talking about those norms within a specific peer group or reference group. Who are those individuals with whom we really compare ourselves and whose opinions are important enough to motivate our compliance with those social expectations. So that's kind of just the background for that. So at the individual level, these norms can be grouped into either kind of people's beliefs or perceptions about what other people in their reference group do as a behavior, or what we refer to as descriptive norms, and then what they believe the members of that reference group approve or disapprove of in terms of that behavior, and that's referred to as an injunctive norm. Now, at the collective level or the group level, these norms are the peer group's actual behavior in the case of descriptive norms, or the peer group's attitude toward that behavior in case of injunctive norms. So I just wanted to make sure we're all on the same page there. So what do we know about the effects of collective norms on modern contraceptive use? So there's a lot of mixed findings, and I don't know if anyone was in the session just before this, but they talked a lot about how there's many differences in definitions and measures and methods used to look at gender norms, fertility norms, family planning norms. And then there's also these are measured in very different contexts as well, so you can imagine. So the evidence has shown us that when we look at gender norms, there are generally, but not always, associations with modern contraceptive use. Although it's important to note that the size and the relative importance of those gender norms can vary really widely across countries when studies have looked at multiple countries. So when we're looking at collective norms around for family planning, either family planning behavior or an attitude, there is just, again, mixed evidence of association with modern contraceptive use. So in looking at the body of literature, we kind of noticed a couple of things. So first was that a lot of this work was really focused on women's contraceptive use. And second, that there had been a lot of development within the DHS program methodologically of thinking about multi-level approaches. So a lot of the previous research that used DHS data did so just using individual level weights. And there's been recent developments in identifying how to use multi-level approaches with DHS data. And so we wanted to try to apply those new approaches. So to that end, we were interested in looking at collective norms around gender, family planning, and fertility, and if and how associations between these collective norms and modern contraceptive use might differ within the same country between men and women. And we wanted to do so using the newly developed multi-level weights. So we selected countries in order to have recent, in the past 5 years, surveys that included men and that represented different global regions of West Africa, Southern Africa, and Asia, as well as having countries from different S-curve categories. So the S-curve is a measure that Track 20 uses, and it's basically a categorization of the modern contraceptive prevalence growth in a country. So with those criteria, we chose Nepal, Nigeria, and Zambia as our study countries. So most of you are likely familiar with the implementation of the DHS. as a stratified two-stage cluster sample. But one thing to keep in mind about these particular DHS studies was that only in Zambia were all eligible men in every household interviewed. In Nepal and in Nigeria, it was a subset. So it was all eligible men in either every second household or every third household that were interviewed. So the average number of men per cluster was much smaller in those two countries compared to Zambia. And then we also limited our sample to married or in-union respondents who were not pregnant or had non-pregnant partners, primarily because we felt like the effect of social norms on contraceptive use would be different for women or men in union versus not in union. And so we used multi-level, multivariable logistic regression models using the cluster as the community. And as I talked about, applied those new multi-level weights. So here's just a snapshot of the number of clusters as well as the number of men and women in each cluster that we had. So the theoretical framework guiding this analysis, as Halima was talking about, so the socio-ecological framework, and you probably recognize Bronfenbrenner's framework, which recognizes that individuals are functioning within multiple contexts of interpersonal relationships, communities, and as well as the larger society. So for this analysis, we were really focusing on the community and the individual, and rather than kind of the societal. So in terms of our variables of interest, we were primarily interested in 3 community-level collective norms. So first were the fertility norms as measured by the average ideal number of children, family planning norms as measured by the proportion of women in the cluster who were involved in decision-making about contraceptive use, and that use or non-use, and then the proportion of men in the cluster who believe that contraceptive use leads to promiscuity. For gender norms, we used the SWIPER Global, which is a globally validated measure of women's empowerment, and it has 3 domains. First is attitude toward domestic violence, social independence, and then household decision-making. We did also include other community level and individual level control variables. So at the community level, these included rural-urban residents, whether distance to a health facility was a barrier, and then the average level of men's education. And then at the individual level, we included age, parity, wealth quintile, and the desire for a child. And importantly, we included at the individual level all of the community level variables that we were interested in, so that the results in the regression is really the effect of the community norm above and beyond the individual's own level of that variable. So what were some of our findings? So just looking at modern contraceptive use among men and women, we can see that Nigeria had a much lower modern contraceptive use than Nepal or Zambia. And Nepal had a significant difference of men's reported modern contraceptive use versus women's, while the other 2 countries had very similar levels between men and women. Looking at just some of the bivariate analysis, we can see that in Nigeria and Zambia, there are some statistically significant differences between the collective norms of modern contraceptive users and non-users, and these were generally kind of in the direction we might expect. So you would see that the ideal number of children or non-users were living in clusters with higher average ideal number of children. The one place where it was kind of in a different direction was here in Nigeria, where we see that non-users were more likely to live in clusters where a woman was involved in the decision about whether or not to use contraception, which was interesting. So we're going to dive into the country findings. And so this is a coefficient plot showing the adjusted odds ratios. So that dotted line at 1 is the odds ratio for 1. So anywhere where the confidence interval does not overlap that line indicates a statistically significant finding. And the coefficients for women are in red and for men are in blue. So here we can see in Nepal that for the community norms, it's really only the community level average ideal number of children that is significant for women's modern contraceptive use, and it's significantly negative. And this makes sense. The higher the community average kind of ideal number of children, the higher the kind of fertility norm in a community, the lower the odds of a woman using modern contraceptives. And none of the other community variables are significant. We do see that for men, higher non-supportive attitude toward domestic violence is associated with a higher odds of using modern contraception. So in Nigeria, we saw that more of the community level collective norms were associated with modern contraceptive use. So for women, we see, again, the average ideal number of children, as well as whether or not distance to the facility is a barrier. So those were both negatively associated with modern contraception. While the community average level of men's education, the proportion of women who are involved in family planning decisions, as well as the proportion of women who have non-accepting attitude toward domestic violence were positively associated with modern contraceptive use among women. For men, we saw similar effects with the average ideal number of children, while the community average level of men's education and the community beliefs that family planning use leads to promiscuity were then positively associated with modern contraceptive use. So finally, in Zambia, we saw that if distance to the facility is a barrier for the community, the average ideal number of children for women, community level of women's involvement in family planning decisions, and then higher levels of women's social independence were all negatively associated with modern contraceptive use for women. Only living in a community with higher levels of non-supportive attitude toward domestic violence is positively associated with modern contraceptive use. And then for men, we see that living in an urban environment, the average ideal number of children, community level of women's social independence, as well as household decision-making were all negatively associated with modern contraceptive use. So only the community levels of non-supportive attitudes toward domestic violence were associated with higher odds of modern contraceptives. So although kind of thinking back to the first slide when I was talking about some of the previous literature, we wouldn't necessarily expect to see patterns or similarities across all 3 countries. We were interested in just seeing if there was anything that jumped out. And I think the main thing that stood out to me from this slide was the pretty consistent negative association of the ideal number of children and how that has an effect on a consistently negative effect on contraceptive use. So one final interesting result is the intra-class correlation, or the ICC, which is an estimate of how much of the difference in individual contraceptive use is due to unmeasured differences in the clusters. So when we look at the ICC of our full model that had all the variables in it, we can tell, I can tell you that how much of the community level variation is unaccounted for in the model. So how much is left over. And so we can see here that even after including all of those things that I previously talked about, there's still a pretty significant amount of community level variation that's unaccounted for, and particularly among women in Nepal and then men in Nigeria and Zambia. So what are the key takeaways from here? I mean, I think the first is, again, kind of reiterating what we kind of knew from some of the previous literature, but that the context really does matter. We see different associations across all 3 countries, and differences in men and women. And I think the slide that I just showed, looking at the ICC, shows that there are still kind of a lot of things that we didn't include in our model that also have an effect on modern contraceptive use. and that varies for men and women. However, despite the fact that context does matter, we do see that kind of the community fertility norm in particular does seem to have a consistent effect on women's modern contraceptive use. We had expected that higher women's empowerment, or higher kind of community norms of women's empowerment, would be associated with higher odds of modern contraceptive use. However, this was not necessarily the case, and often we saw negative coefficients, even if they weren't actually statistically significant. And I think this kind of echoes some of the conversations that we've been having in this entire conference about, is kind of contraceptive use kind of the best outcome that we could use here, and would we necessarily, or maybe think about women's empowerment being associated with a measure of potentially reproductive autonomy or kind of contraceptive agency rather than actual contraceptive use. And finally, just that, it's something I think we probably all already know, but, measurement of norms is really challenging. And, we use these measures because that's what we have in the DHS, but there may be better measures of norms, and there likely are better measures of norms. And as well, thinking about what I talked about in the very beginning about the reference group, and you want to measure norms among a particular reference group. And we used cluster because that's the way our data are kind of set up. But is there potentially a better reference group within which to look at those norms, and how can we identify that? Thank you so much. And if you're interested in reading the full report, which goes into a lot more depth, so this is the full report. We also have a research study storyboard, which distills a lot of the key messages from this study, and it's much prettier and much more fun. So you can look at either one of those. And for the researchers out there, if you are interested, all of our code is available on the DHS program GitHub site. So if you're interested in replicating or just looking at the code, you can access that as well. And that's all. So thank you very much.
Maybe you can flip back to the other slide.
Yes, sure. Yeah, this one.
So much, and it's we'll just leave that slide there for a second. It's always refreshing to see immediate kind of access and transparency of how you got to the results, and for others to see that. I have a slightly longer introduction, so we can leave that here while I introduce our final speaker. Rachel Gronowski is a policy research analyst at the University of California, San Francisco, where she conducts research on women's global health with a focus on social and gender norms and reproductive health. She also supports the Self-Injection Learning Exchange, which is a learning collaborative researching best practices for implementation of contraceptive self-injection in Kenya, Nigeria, Uganda, Pakistan, and India. Rachel graduated from Princeton University in 2020, where she focused on health policy and earned her master's degree in global health sciences from University of California, San Francisco this year. Congratulations. And she will attend Tufts University School of Medicine. Well, you're doing that now. It's the fall. Oh, next fall. Okay. Where she plans to specialize in obstetrics and gynecology. So Rachel will step to the mic and present results, adapting and validating the gender norm scale in Nepal. Please, Rachel.
All right, thank you so much for that introduction. And I'm very excited to be presenting my research today, adapting and validating the gender norm scale, or G-norm, in Nepal, an examination of how gender norms are associated with agency and reproductive health outcomes. And I would like to thank all of my co-authors, especially Nadia Diamond-Smith, who is with us here today. So I'm going to be building a lot on what Sarah just talked about. But really quickly, just to refresh our definition of gender norms. Gender norms are a subset of social norms that describe standards and expectations for how people of a particular gender are expected to act. They are embedded in our institutions, reproduced through social interactions, and differ between cultures, communities, and contexts. Importantly, while norms are deeply rooted, they're not immutable and can be reshaped through targeted policies and community-based reformations. So, as we just talked about, gender norms serve as a critical determinant of sexual and reproductive health by restricting female autonomy and empowerment. One framework for conceptualizing women's empowerment outlines the interconnectedness of three spheres: agency, resources, and institutional structures. Gender norms and other social norms influence all three spheres, with research showing that inequitable gender norms limit female autonomy regarding sex, marriage, and contraceptive decision-making, restrict access to critical resources such as healthcare and family planning, and sustain imbalanced institutional power hierarchies, which consistently restrict the rights and opportunities of women and other gender minorities. Other research has shown that women's empowerment and social and gender norms are associated with reproductive health-related constructs, such as family planning use, fertility desires, abortion, ideal age of marriage, and gap between marriage and first birth. So, as gender equality gains recognition as a global health priority, there's been a call to action to further elucidate how gender norms are related to family planning use and to incorporate norms into family planning programs. However, there still remains a notable measurement gap, as we've been talking about. And specifically, as Sarah touched on, while many researchers are measuring individual beliefs or behaviors, current scales often don't acknowledge the crucial interdependence between reference group expectations, like our family, friends, communities, and social action, which holds norms in place. This relationship can be captured by incorporating aspects of social norms theory, specifically distinguishing between descriptive and injunctive norms, which she just touched on. And just as a reminder, an example of a descriptive norm, or what we think people in our community are actually doing, would be most women in the community need their husband's permission to access medical care, whereas injunctive norms are perceptions of gender expectations, or most people in the community believe women should need their husband's permission to access medical care. And this recognition of injunctive norms is especially pertinent to public health because they serve to motivate our behaviors to seek social sanctions or to avoid, or to seek rewards and avoid social sanctions. So, what I'm here to talk about today is the gender norm scale, or G-norm, which tries to address this measurement gap. So the G-norm is a novel scale that measures perceptions of community-level gender norms, and it was originally developed in Odisha, India, in 2020. And here to the left, you can see an abbreviated version of the India G-norm, where we have two scales corresponding to descriptive and injunctive norms. And the way it works is that women respond to each item along a Likert scale of strongly agree to strongly disagree. And then we can add up those scores to make a G-norm score, where a higher score would indicate more equitable norms. And in this paper, we tested its external validity by showing how we adapted and validated the G-norm in the Nawal Parsi district of Nepal. And we also demonstrated construct validity by examining associations with sexual and reproductive health-related constructs. So we had three hypotheses here. Firstly, we hypothesized that, like in India, a factor analysis would result in two separate subscales corresponding to descriptive and injunctive norms. Secondly, we hypothesized that gender norms would be more equitable among more educated women and among women who were members of a higher ranked caste. And finally, we hypothesized that more equitable norms would be associated with higher scores on a decision-making scale, increased odds of intent to use family planning, a higher ideal age at first marriage, and a wider ideal gap between marriage and first birth. So turning to our methods, data used to adapt and validate the G-norm scale came from the last wave of a longitudinal study examining nutrition and gender empowerment among newly married women in the Nawal Parsi district of Nepal. This region is in a southern stretch of Nepal bordering India, and it's highlighted in the figure up at the top. It is more socially disadvantaged compared to other rural areas of Nepal, and the status of women is lower as measured by household decision-making. Study participants were 187 newly married women between 18 and 25 years of age, currently residing with their mother-in-laws. So we adapted and validated the G-norm in 5 stages. First, to determine which prior items from India remained relevant to our new cultural context, and to develop new items, we analyzed qualitative data. We conducted 60 in-depth interviews with newly married women, as well as their husbands and mother-in-laws in the same districts, in efforts to understand their concerns and experience with marriage, fertility, and health. We found 18 items from the India G-norm remained relevant, and also added 10 additional items for a total of 28 items. After we translated our items from English to Nepali, we conducted 14 cognitive interviews with women of reproductive age in the same study areas. And here, participants were asked to respond to each question using the Likert scale, as well as to reflect on how they came to their conclusion and whether the item was at all confusing. We then revised our items based upon participant feedback, working closely with country partners throughout the process to ensure that scale items were culturally relevant and appropriate. The G-norm items were then administered to 187 women between November and December of 2019. And after data was collected, we determined the dimensionality of the scale, identified and removed poorly performing items by applying an exploratory factor analysis, and then validated the scale by applying a confirmatory factor analysis and examining outcomes with constructs hypothesized to be associated, such as decision-making and intent to use family planning. So turning to our results, here we can see a description of the sample. We can see that the majority of women completed grades 6 to 12, were Hindu, had arranged marriages, and had prior experience with contraceptive use. And here we have our final G-norm scale. I'm just showing one subscale at a time because it doesn't all fit. But we can see that our initial psychometric analysis showed a 2-factor solution corresponding to our 2 distinct subscales of descriptive and injunctive norms, with almost all descriptive norms loading onto factor 1 and almost all descriptive norms loading onto factor 2. We narrowed down the scale from 28 items to 20 items by removing items that either had factor loadings below 0.4 or loaded equally onto both factors. We also see that both factors had high Cronbach's alpha scores, which meant that the set of items were closely related to each other, which confirmed our hypothesis of a 2-factor solution. For a second and third hypothesis, we looked at associations between demographic variables and G-norm scores, which again were calculated by adding up the participants' responses so that a higher score indicated more equitable norms. We did find that women in higher castes reported more equitable G-norm scores than women from lower castes, and that women who were more educated also reported more equitable gender norms compared to less educated women. Interestingly, our findings also indicated a discrepancy between injunctive and descriptive norms, with lower descriptive norms than injunctive norms in the overall sample. This shows that many women feel as though they should have certain rights or injunctive norms, but in reality are often not able to actualize them. Finally, I forgot to switch the slide before. Finally, looking at associations between G-norm score and reproductive attitudes, we found that higher or more equitable descriptive norms were associated with having higher scores on the decision-making scale, disagreeing that it was wrong to use contraception to avoid pregnancy, and higher ideal age at first marriage. For injunctive norms, only strongly disagreeing that it was wrong to use family planning was associated with more equitable gender norms. By capturing perceptions of community-level gender norms and exploring associations between gender norms and reproductive health attitudes, the G-norm provides a valuable tool for interventionists working to reduce gender inequality and improve sexual and reproductive health in Nepal. Our finding that injunctive norms differ from descriptive norms indicates that perceived expectations may be changing faster than perceived behaviors, and illustrates the benefits of separately analyzing these 2 subscales. However, more work is needed to investigate the relative immutability of descriptive versus injunctive norms. So some final thoughts. Gender norms serve as a foundational yet often overlooked determinant of female autonomy, empowerment, and sexual and reproductive health. Operating norms differ by cultural and socio-political contexts, highlighting the value of measurement tools adapted to particular settings. Given that global crises such as the COVID-19 pandemic have been shown to threaten gender equality, as well as the recent rollback on reproductive rights in the Western world, it is now more important than ever to properly measure how and which gender norms are changing. We are now currently working on adapting the G norm to Nigeria and Uganda, and there's also interest in creating a more universal, shorter set of G norm items to measure and compare norms between countries. Thank you so much, and please reach out with any questions.
So we have time now for your questions and comments. I'd like to invite the presenters to this table here because it has a mic. So please, if you could come here. And is it possible to put the QR code for interpretation in case there are new attendees in the room who would like to use it? And in the meantime, please come to we have 2 mics here for you to use for questions or comments, insights, frustrations that you have in this thematic area. The floor is open, please. Maybe I can start us off. And this is the last session, so this is your last chance to give voice to the things you have been struggling with over this conference, or I guess one overall question I have, and it relates to all 3 presentations, is this tension on the area of gender norms, of the pursuit of something standardized and applicable across different contexts versus really responding to what gender norms look like and how they affect people's lives in a particular context. This is a it's a very general point and tension, and I wonder if each colleague here might be able to share what they think. Is it be extreme? Is it really fruitless to pursue something that is applicable but perhaps not entirely meaningful across different contexts? That's to get the ball rolling, so to speak. Please let me turn back again to colleagues here to add on before we turn to our presenters.
Good afternoon. Thank you very much for all the presentations that have been made. My name is Wilson Senyoni. I work with Oxfam in Uganda, and I did follow well all the presentations that you made, but I have 2 questions. One will go to the second presenter. Are you planning to conduct any other study using other indicators of social norms alongside what you used in this study? Because I know social norms are quite diverse, quite broad. Yes, this gives us some good picture, but it would, I think, be very important to also use other indicators while conducting other studies around social norms. Then to the last presenter, I would like to find out if in your study you were able to engage cultural and religious leaders in your study, just to get their perspectives. Thank you.
Thank you so much. Let's start with those two, and then we'll open back up. So
Yeah.
please, if you want to begin.
So to your
Sarah?
point, to your question, Anne, I mean, to me, it seems like it really depends on what the goal is or what you're trying to do. And I think, as a researcher, I think sometimes there is an interest to have standardized measures, whether or not they are, the most precise, but to have something that you can compare across countries. I think there, could potentially be value in that. But I think if you're looking more at an implementation program or something, I think you really need to, as I think all of our work showed, I mean, you really have to have things that are very specific to that context. And so understand, have measures that really reflect the social norms in a particular context. And so, I mean, just say yes, both, would be my answer to that. And then just to the question about if we have, if there are plans to add other social norms or add on to this research. I mean, I think we don't necessarily have plans in the future, but the code was there. If you would like to, look within the DHS program data sets and see if there are other norms that you feel like, we did not include, I would encourage people to, replicate this or add on if there are other things that we missed. But we personally, at this point, don't have plans to add build other social norms into this particular analysis.
Thank you so much. To your question, Anne, I'll have to echo Sarah in saying yes, both, it depends. Similar to what you said, if you're looking to try to understand how specific gender norms are presenting in a local context, it is nice to have that specificity. And what we've seen in terms of adapting the gender norm scale from India to Nepal to now Uganda, the salient gender norms in each community are different. And even within a country, based on the different communities you go to, are different. And there is value in having that detail and that distinction. That being said, if you want to make comparisons, if you wanted to, for instance, set a benchmark, identify outliers, set a goal, it would be useful to have standardized measures. So it just depends. And then in response to the specific question, if I understood, were you asking whether or not we asked the scale items to people other than women or other people in the community? Yes, so that definitely is one of the limitations of the study, that it was the survey was only taken by women, but in our qualitative analysis at the beginning, we did interview women, their husbands, and their mother-in-laws in order to get a sense of the norms in the community from all perspectives. In the future, it would be interesting to ask the scale items to husbands, to other community members, to see if there is a difference in what women perceive as the descriptive and injunctive norms, as opposed to men.
Yeah, we have a technological problem, problème technologie with the interpretation. Or do you want to? No.
You have question?
Right. So we have a gap with the interpretation. Unless Sarah, you could communicate the first question. I apologize.
Good morning. Now, the question which was addressed to me is whether could we have global norms in this study? Yes, I think it would be specific because, as we have seen, the study which was undertaken in 3 different zones in the country, we have the Loga zone, Dosso, and Duti, the 3 zones. So we noted that the approaches are not the same in terms of value addition. So to each group, there are specific characteristics. That's why we used different types of strategies or approaches. And you noted that in the study, we see that depending on the area or zone, there are areas where the the migration also matters because sometimes the people migrate to go to the towns to look for resources during the rainy season. So each area has its specific characteristics, but generally the study can be relayed at all levels, but taking on board the specific characteristics of each society. Thank you.
And all those presentations were really interesting. Obviously, Sarah's work I'm very familiar with because I was part of that study, but I have a question for just to think about that has occurred to me as we go through this. And it's, I think, relates specifically to the issue of really being careful around identifying reference groups and understanding why, you know, whose opinion are we, whose norms are we talking about in a community? And I think to the earlier question around asking men and asking other people in the community, I think social norm theory understands norms to be collectively held, but then the reference group opinion to be particularly influential. And so I think both of those pieces are important potential ways to move forward, though I would love to hear your thoughts on that. And then I think related to that is, you know, issues of power and influence in the community. And I guess all of us perhaps having to think about, you know, we may be able to identify a reference group, but if that reference group is not particularly influential in terms of their ability to act on their preferences and norms, then how much is that going to matter? We may not find, I would imagine, you know, if, for example, we could see that adolescents have very different ideas of how they should live their lives than older people in the community, but are they able to act on those? Even if they would like to, where's the power in the community, and how do we, I guess the real issue is, how do we balance these in our work? And, you know, I think it's great. This is complicated stuff. We're still learning how to do it well, and it's all small steps, but this is just some of the big issue and questions that come up in listening to all of this. Thank you.
All right, good morning, good afternoon. So my name is Doris from Nigeria. I came a little late, and I think I made the last 2 presentations. So my question is just in addition to what the last speaker just asked. And I know you said, both of you actually said that measuring social norm change is actually that it has its own challenges. So I just wanted to find out that in all, because for me, I think one major challenge you see, particularly in working, in changing social norms, is actually how to measure the change for you to actually know that this intervention I did actually led to this, and this is the norm change now that you have. So I don't know if there are plans for future research on that to actually have a clear measurement of what social norm change really is and how to really know that your intervention worked. Because I am very, very interested in that area, particularly working with faith leaders and men. And maybe that's why when he said it now, I actually realized that women, yes, but you like it or not, in most African setting, it's the men who uphold because they have the power, they have the influences, they uphold those social norms, definitely to ensure women don't get that agency they need to do what they need to do. So I will really need to know if there are plans for that. Thank you.
Before we turn, if there's one more question, and then or comment? Yes, please.
Hi, thank you very much for your presentations. My name is Hiromi Kusano. I'm from Joycef, AO NGO. We do family planning and SRHL delivery, both in not delivery, but human resource education in the countries in Africa and also in Japan, youth advocacy. My question is that I was wondering what choices of contraceptive in each country they were able to use, and or each individual were able to choose to use for themselves. I'm asking this because there are only limited number of contraceptive available in Japan, and then that is male condoms, and then oral pills and IUDs. And then male condoms are most commonly used because it's convenient and it's cheap, but both oral pills and then IUDs are rather pricey. Oral pills is something like $40 in USD, and then IUD, in order for you to put it, it will cost you like $500. That kind of stops people from using that. So all these things considered, it's also gender norms, but it's also other issues involved in order for you to make decision whether or not to use contraceptives. So I was wondering how many options of the contraceptives they had, and then who made these options, what could be available in their society as well. Thank you.
So just to Jeff's question, I mean, I think that's a lot of what we struggled with, I think, as you know, with our, the DHS study, and, we have a certain set data set, and so, we kind of grappled with, well, maybe these aren't perfect measures, but I think, if I was designing my own study, I mean, I think there would be a lot around social norms. I mean, I think that there would be a lot of formative research that would go into that process of really identifying, like, well, what's the group that we're really interested in, and then, who are, what is the reference group for those social norms, so that you kind of have that mapped out before you go in, and then, if you're doing, quantitatively, then you have enough sample size to actually talk to those people who are important, and so I think that just speaks to the importance of formative research in the place where you're interested in kind of looking at these associations and the effects of social norms. And just speaking to the question about the different options of methods, I mean, we did find, we didn't really go into a lot of detail about the different kinds of methods that people were using. I mean, there was a variety in different countries. There are certain methods that are more prevalent. So, in a lot of the African countries, the injectables are much more popular compared to, say, like sterilization. And so, I mean, I think that probably has something to do with it. I mean, I was also interested, I mean, this is kind of related, but in kind of looking at this among women in particular, and kind of covert use versus non-covert use, and how, gender norms might be associated with that as well. So I can maybe get back to you if I can look a little bit more, but I know in most of these countries, there are more options than what you were, I mean, there's, the different kinds of injectables, implants, IUDs, pills, condoms, no condoms, and things like that.
Speaking a bit to the question about the change of norms over time, I am definitely just getting into this field, so I'm not positive, but I know that a lot of work needs to be done to think about how quickly or slowly norms change over time. And once again, that depends on who you're asking and in what context and in what reference group. Why I think measures such as the G-norm, which are quantifiable, even though not perfect, could be useful, would be to establish a baseline, conduct some sort of intervention, look at a policy change, and then either in the short term or in the long term, you could measure a change in score if you're asking members of the same community across longitudinal time points. And that would be really interesting to do. I don't think we have any plans to do that as of now, but would definitely be another interesting application. In response to the question about the different types of family planning available, as Sarah mentioned, I'm not positive, but there are a wide range of options. But I think that also just goes to show that social and gender norms are just one part in the whole spectrum. You can't forget about resource availability in terms of healthcare access, in terms of overt versus covert use. While complicated, you have to keep all pieces in mind. So you can be looking at gender norms that over here there's no access, and that would definitely affect someone's intent to use family planning. So that is definitely a valuable point.
I had a question. J'avais une question pour vous. C'est par rapport à la choix des facilitateurs.
The choice of facilitators, community facilitators. How did you choose these people who undertook discussions with the husbands? Because I thought that the selection of people, the choice of people, is important in this particular context. So it's important to know who is going to talk about this topic in a community. So for the success of the project, the people who lead the conversations must be well chosen. So how did you select such people? Thank you. Thank you for the question. Now, in my presentation, thank you for giving me the floor. In my presentation, we talked about the methodology and how the community facilitators and mentors were chosen, were selected. For instance, when you look at the level of use for adolescents, we looked at age. We introduced the age bracket 10 to 19, and the married people living with their husbands. And then we looked at the favorable acceptance by the husband. It's the husband that gave the green light to the wife to go for contraception. So all this depends on those people. Then for the villagers, also we use the people. And here, we looked at the rate of family planning use in a specific area. Now, concerning the identification of mentors and facilitators, we tried to look at the young people who have the same age as the target population, because we need to have people with the same interests, and they can understand each other better. That's the peer education system. So they were selected in the communities by the people who are credible in their communities and with whom they share the age bracket, because people that were chosen were aged between 19 and 25. So that's why we were able to identify those people in the communities. Did I understand you? Rather, did I respond to your question? Yes.
Chose the community facilitators and mentors, because who those people are would be really important to kind of, this reference group as we were just talking about. So she was saying that the community facilitators were actually adolescents from the community that are of similar age to the adolescents that were kind of the target audience. 16 to 25-year-olds that were identified from the community and then trained in how to do those kind of group discussions.
Oops. We're nearing the end, but we have a couple minutes. Last chance. Please.
Thanks for these great presentations. Just quickly for the last two, I thought it was, I think it's interesting sort of thinking about the relationship between gender norms and empowerment. And, I noticed in the DHS one, I know you are obviously limited with what's in the DHS, and you sort of tried this approach of measuring empowerment by like measuring gender norms by pulling up the empowerment. And I just wondered your thoughts. I mean, obviously, I'm biased because Rachel's was based on data from a study of mine and Mahesh's in Nepal, but there we saw that there was an association between this gender norm scale and then those individual decision-making questions. And so I just wondered sort of like your thoughts more broadly on the relationship between the two, and like maybe if that's the case, that they are associated, like could we just use those household decision-making measures as a proxy for gender norms, which is I think what a lot of people end up doing in their DHS analyses, or I don't know, just wondered what your thoughts were, or anyone else in the audience also.
Yeah, I mean, that's something that we selected the swiper just because I think it's one of the, we didn't want to just focus on kind of household decision-making. We wanted something that was a little bit more broad. But I was interested, especially after seeing the really mixed findings and a lot of kind of negative, like associations that just were kind of in the opposite direction that we would have thought, that, looking at, kind of pulling out even some of the specific items from the swiper, or looking at things a little bit more in depth to kind of just try to understand all of that, which we haven't had a chance to do yet, but I think would be interesting, or even looking at kind of other ways of conceptualizing empowerment and gender norms, because, it just wasn't kind of what we expected that we saw, so.
Okay. Could we please thank again the presenters for sharing really interesting work, and that introduces even more questions and things for follow-up than, well, I'll leave it there. Thank you.